The presentation is Healthy Aging, Resilience, and Mental Health Across the Life Course. Theodore Cosco is Director of the Precision Mental Health Lab, Associate Professor in the Department of Gerontology at SFU, and Research Fellow at the Institute of Population Aging at the University of Oxford. Conducting his doctoral and postdoctoral training in epidemiology at the universities of Cambridge and Oxford, respectively, Dr. Cosco is a chartered psychologist with the British Psychological Society, passionate about mental health across the life course. Using a transdisciplinary approach, implementing both qualitative and quantitative methods, he is interested in developing strategies for how to be happier and healthier for longer, particularly through technological means. For contributions to the field, he received the Early Career Achievement Award from the American Psychological Association, the Stan Mays Early Career Award from the European Psychology Society, as well as the Canadian Association of Gerontology's Movement Investigator Award. When he's not pacing around his office drinking coffee, you'll find him chasing salmonids with a fly rod or cooking over an open fire. So thank you very much, Theodore.
Thank you for having me. And I sincerely appreciate you accommodating me over Zoom. I'm in the UK at the moment, so I appreciate everybody who's there, and apologies for having my face plastered at a size that I don't think it was built for. So today I'm going to be talking about healthy aging and resilience and mental health across the life course. So I think it's important at the outset to set the stage for why studying aging is important, and also looking at what is successful aging and looking at some conceptual frameworks with respect to healthy aging, as well as resilience. I'm sure we've all heard a number of different flavors of resilience, and I'll pose to you one version of resilience that we use in this model. And then looking at a life course perspective, and this is more of a methodological piece, and looking at how using a life course perspective and longitudinal methods can be really useful in this context. And then tying that all together with respect to mental health and looking at one specific study that involves conceptualizations of successful aging and resilience, using a life course perspective and looking at how mental health is impacted across the life course. So aging, why is it important? I think that we all experience aging in our own ways, and it's something that's being experienced in Canada at a scale that has never been experienced before. In 2016, there was a historic demographic shift where there were more older adults aged 65 plus than there were children in the Canadian population. And this is a trend that is expected to continue. So we're facing increasing numbers of older adults in the population. And so looking at how we can foster better outcomes, particularly with respect to mental health, is really a focus of mine. And one of the interesting pieces of aging in Canada is that it's not happening at a uniform rate across the country. So if we look at the number of people aged 85 plus in 2001 versus 2021 by province and territory, there is a huge difference in the absolute and relative numbers of people that are in these age brackets. So the heterogeneity of the aging process is something that is really interesting and makes studying mental health across the life course really interesting, but also very frustrating because there's lots to unpack. So successful aging is a term that's very popular, and I was trying to provide some context to what this means and why it's a useful or not so useful definition, but it provides some historical context in how we get to models of resilience. So the historical successful aging model really stemmed from Jack Rowe and Bob Kahn. In 1987, they published what they admitted to be sort of a back of the napkin paper in Science that talked about successful aging being not having any diseases, high level of physical and cognitive functioning, and being engaged. And this was it really set off a whole revolution in the conceptualization of aging models in a positive way, but it became obvious that this was not a totally sustainable model. I had the opportunity to write a book chapter with Jack Rowe about 30 years after he published the original successful aging model. And in this, we talk about how looking at a really high level of functioning across the life course isn't necessarily a model that is sustainable or realistic or inclusive. And so we're looking to other definitions and looking at models of aging that go beyond just this high level of functioning, and which is what successful aging being 2.0 being something that was referred to as resilience in some contexts. So if you look at these historical models of successful aging, we've got in the y-axis, we have functioning And then in the x-axis, we have adversity. So in these historical models of successful aging, basically, if you were in this highest functioning bracket here, you were successfully aging. So regardless of the level of adversity that you're experiencing, your level of functioning is high across the board. This is important to note, and this is sort of framing it up for how we moved on from these models. So looking at resilience, and we talked a lot about the resilience, the conferences about resilience, and there are lots of different flavors of resilience. So recently, did a systematic review of operational definitions of resilience, and actually, shameless plug, check out this book that we co-edited on resilience and aging. And in this, we look at conceptual models of resilience and aging and how we frame this up. And one of the key takeaways from this model is there are basically two major components of resilience. And every model that you have, every flavor that you have has these two components. You have some form of adversity. It can be physical, it can be psychological. And then there's some sort of positive response to that adversity. It can be physical, it can be psychological, it could be any range of different things. But when you have the combination of the two, you get resilience. So in this framework, we were looking at resilience as being a response that is more positive, or an outcome that is more positive than would be expected given the level of adversity that an individual experiences. So returning to the same figure, we've got functioning in the y-axis, adversity in the x-axis. Within that model, if we look at resilience being a better than expected outcome based on the adversity that you experience, we would expect that for an individual, and this plotted line is expected level of functioning, you expect that somebody who has a low level of adversity, they would have a high level of functioning. Equally, somebody who has a really high level of adversity, you would expect them to have a low level of functioning. So it accommodates the levels of adversity that are experienced in a way that looks at adversity and individual circumstances. So in this model, everybody who's above this hypothetical example in the cross-hatched area would be exhibiting resilience. They have a better than expected outcome. And this is important in a framework. So we return to successful aging, where you just have high levels of functioning regardless of the level of adversity that you're experiencing. If we look at how resilience overlays this, it provides a different perspective on how more inclusive models of resilience are. And if you are a researcher, if you're trying to get people into this highest functioning bracket, that can be unrealistic and totally infeasible. But if you're trying to foster resilience or better outcomes, given the level of adversity that they're experiencing, this is something that has a much stronger public health message, and something that everybody, dynamic resilience can be fostered at the individual level. So this is sort of a conceptual framework to give you where we're coming from in this example for resilience. So life course perspectives. Today is all about looking at things from lifespan, and I think this is an incredibly important thing to be examining. Longitudinal analyses are a fantastic way to look at life course perspectives, and the UK has done a fantastic job of looking at setting up studies that have lasted a very long time. One of these studies is the National Survey of Health and Development, also known as the 1946 British Birth Cohort Study. So about half an hour tube ride from where I'm sat right now. In March of 1946, they recruited 5,362 babies that were born in that 1 week. And they recruited them. It was originally for a study of maternal health and outcomes, but they followed those 5,300 then babies for their entire lives. So they are now, 73 years old. And they have had, or some older than that, have been followed up their entire lives, and they've had prospective data collected throughout their lives. So when they were children, they were being surveyed. When they're in midlife, they're being surveyed. And when they're older adults, they're also being surveyed. So there's a huge wealth of information that's been collected in this study. And it's also been prospectively collected. So it's not asking somebody who's 70 years old, tell me about about your experiences when you're 15. It's when they're 15, they oftentimes had the teachers would fill out evaluations on the students that were selected for the study. And as a personal note, and a really poignant demonstration of the heterogeneity of the aging process, in 2016, I was actually working in London, and the study participants had their 70th birthday. So they all came down to City Hall in London, and we had a birthday party. And as a poignant example of the heterogeneity of the aging process, everybody in this photo is the exact same age. These are the study participants that actually came down to the birthday celebration. So we really got a firsthand perspective on what the aging process looks like for these 7-year-olds. So with this data set in mind, and coming back to a resilience framework. So we talked about having resilience being a better than expected outcome given the level of adversity that's been experienced. And within longitudinal studies, if you have adversity that happens at time X and the outcome that happens at time Y, you can look at what happens between these. What are the types of resources that can be invoked that will offset some of the adverse circumstances individuals find themselves in to foster better outcomes. So this is something that I'm really interested in. And in this type of mediation analysis is looking at in the relationship between the adversity and the outcome, how much of that relationship goes through this pathway, through these resources, and how much of this relationship can be explained via the resources. How can we offset negative outcomes by invoking these types of resources? So within the National Survey of Health and Development, conducted this study that you can check out in more detail with respect to some of the methods and analyses, but wanted to look at what's the relationship between early life adversity and later life mental health within a longitudinal population-based birth cohort study, and what are the types of resilience resources that offset these later life mental health challenges. So the adversity we looked at was early childhood adversities, and the outcome being mental distress. How we captured this was we looked at a number of different factors, put together a composite metric of everything from maltreatment to low parental concern, what they called affectionless control, which is a sort of a negative parenting style. And these were completed up until age 16 by the study participants' teachers. So we had collected all these data from up to age 16. And then the outcome that we wanted to look at was collected at age 53, age 60, and 68, and using the general health questionnaire. And it's basically a generic metric of mental distress. So we have these early adversities up to age 16, and then at age 50, 53, 60, and 68, we have 3 different time points where we've collected mental distress, which makes it really interesting to be able to look at in the time frame that's in between that. And within that, in between age 16 and 50s, 60 and 68, we wanted to look at resources. So what is the role of physical activity? What is the role of socioeconomic position? What is the role of social connectedness? And what is the role of neighborhood cohesion? So the model that we wanted to look at was looking at the levels of adversity that the study participants face up to age 16, and they're looking at, on the other end of the spectrum, their mental distress at age 53, 60, and 68. What does that relationship look like? Is there a relationship between, we hypothesize that it would be poorer mental health outcomes with greater adversity, but also looking at, is this mediated through the pathway of physical health, through socioeconomic position, through social connectedness, or through neighborhood cohesion? So we had hypothesized that having greater resources, so higher physical activity, higher socioeconomic position, greater social connectedness, and greater neighborhood cohesion would offset some of the negative impacts of high adversity and have better mental health outcomes. What we found was we didn't find a relationship between childhood adversity and physical activity in midlife. So this was not mediated, and same thing for socioeconomic position. But what we did find was there was a relationship between this mediation pathway through social connection and through neighborhood cohesion. So what this means is that if we look at the relationship, the level of adversity experienced in early life and the amount of mental distress experienced at age 53, 60, and 68, around 25% of the variance in that relationship was mediated through a social connection pathway. So about a quarter of the relationship between early life adversity and mental distress could be explained by variations in social connection. And then when we look at neighborhood cohesion, about 10% of the variance in the relationship between early life adversity and later life mental distress was through that pathway. So what does this mean? What it means is that if we've got some really excellent intervention targets, because if this is happening at age 16 and this is happening much later in life, if we're able to intervene at some point, this was collected at age 40 and 50. So if people have greater social connections in midlife, they can offset some of the adversities that they experienced decades earlier and have a positive impact decades from these positive resources being brought into their lives. which is really interesting and provides a really excellent sort of hypothesis for prospective intervention pathways. To sum up very quickly, aging is incredibly important. Everybody is slightly older now than they were at the beginning of this presentation. It affects everybody, and the population is aging at an unprecedented rate. Healthy aging and resilience are two models that have been put forth to try and look at how we age and what are the positive aspects of that. Resilience being something where we're trying to foster better outcomes than would be expected given the adversity that's being experienced. A life course perspective incorporates everything that happens in your life. Everybody is the byproduct of a life's worth of experiences, and all of the complexity of everything that happens to an individual is very difficult to unpack in a research study. But in the one that we looked at here, looking at early life adversity and later life mental health, we found that social connections, both at an individual level, sort of connecting with people socially, also at a neighborhood level, was associated with better mental health outcomes. And that provides a really excellent hypothesis for pathways to intervention in the future. So thanks so much for your time. I really appreciate you allowing me to zoom in from afar, and I'd be happy to take any questions that you have. Briefly like to thank people that provide the cash that allows me to do what I do, and I'd be happy to take any questions that you have. Cheers.
Thank you, that was fascinating. I'm already standing up for the questions, so I'll just zoom down here.
Thanks, Teddy, Brian from SFU. Nice to see you on the screen. Great presentation, really fascinating longitudinal prospective study, and really interesting to see these effects on mental health throughout the lifespan. Just given my bias as a researcher, I'm curious to know whether or not those participants were also studied from a cognitive perspective in terms of how these early life adversities affected late life cognition, disease status, dementia. Was that looked at in this prospective study?
The short answer is yes. And if you want to go down this rabbit hole, the 1946 birth cohort study was the first of many. They did one every 12 years. So it's the 46, the 58, the 70. And they have, in the later stages of the study, they have incorporated measures of cognition. And even more interestingly is they're actually doing brain imaging in these studies. So you can look at a prospective study that has data that was collected about maternal health and maternal nutrition, and then the baby's born, they're followed up, and then you can look at cognitive deficits at age 75. So it's a huge wealth of information, and I would definitely recommend checking it out. And yeah, so they have collected it. One of the caveats with that is the later studies that you don't see a lot of change. So it isn't until you get into the later stages of the study that you have numbers that give you enough power to do any sort of meaningful analyses.
Thank you.
Okay, I'm gonna check on, okay, yeah, question. Thank you.
Great talks, Randy. I can talk for the rest of you. I really like the outcome of the study. So impressions about sort of timing of certain events. You had mentioned curious, for example, the adversity that you were looking at in terms of the practice was that occurred when they were in their teens. And then you have social factors, environmental factors mediated how that affected their mental health later on. Because the question is, was that social factor sort of continues across that time period, or was it more biased towards when the adverse event happened, or when the mental health changed?
So you can see the last part of the question. So I heard again, is there some sort of bias introduced in midlife?
Bias, it's more a question of like, so for example, social support. Is the social support there when they experience the adverse event, or was the social support stronger when they control the mental health change? So, or does it continue to cross the entire spectrum since so that fit to
Yeah, so the social support was captured in their 40s and 50s. So it was the early childhood adversities in the teens, and then in the 40s and 50s there was the resources, and then at the very several years later or decades later for the 50, 63, and 68 data collection waves. So it was after. So there was a big temporal break between each of those. So we could look at So it's not, you're not getting, or trying to, as best you can, rule out reverse causality. Because if you, in a cross-sectional study, obviously, if you measure two things at the same time, it's difficult to know which direction it's going. But if you look at, there's a 10-year break between social connection and the outcome measure, there's more evidence towards causality, not necessarily conclusive. I would say that the complexity of aging cannot be understated. And to think that social connectedness and the number of people that you have in your social network is the causal mechanism that is underpinning that 25% mediation, I think that would be a little ambitious. I think that there's so many different things that contribute to social connection, because you have physical capacity to connect with people. You have the neighborhood you live in. There are many different factors that are contributing to even your capacity to engage in social connection. So it's exciting in the way that epidemiology points a finger at there's a relationship between X and Y. But we need to do some much more investigation to really unpack what the true causal mechanism that underpins that relationship.
Okay, this is Kelly Shen from SFU. I'm going to read some of the questions showing you will see in the chats for the in-person audience as well. So from Susan Fitzpatrick, does it matter how one perceives either the adverse influences or the possible mitigating factors? And to what extent might temperament or other interpersonal factors influence resilience?
So I think one of the exciting and frustrating things about studying mental health is it's very individual. The way that an individual experiences adversity, the way that an individual experiences a psychological outcome is totally individual, and your perception of the level of adversity that you're experiencing and your perception of the outcome is really what matters. And that is particularly when these data are being captured via psychometric scales that are self-report, which is a limitation of the study, obviously, but it's, to my mind, everybody's experiencing mental health in their own way, and we're trying to foster mental health in a more positive way, in the way that individual is experiencing it. So in answer to your question, it's the perception of one's adversity will impact how the perception of their adversity will impact how they're impacted, or how they respond to that. And so it gets a little bit challenging. And this is a limitation of the study that we talk about in the bigger paper, is that we're looking at the adversities are things that were reported by teachers in a lot of instances. And so there's like an objective third person that is putting in whether or not they experience the adversity. And then when we look at the outcome being mental distress, that's a self-report metric. So that's your own version of what you feel is or is not distressing. But yeah, it is. And that's sort of the noise that you get in these types of studies, is where everybody experiences the adversity differently. So you really need a lot of people in the study to be able to look at it, to try and find that signal within all the noise that is presented. And what was the second question? Sorry.
To what extent might temperament or other interpersonal factors influence resilience?
Oh, sorry, just cutting out a little bit there.
It was about temperament or interpersonal factors and how they influence resilience.
Oh, okay, I'm reading it now. There we go. I think that there is temperament and interpersonal factors absolutely influence resilience. I'm sure that we talked about it today as well, is there's things like sort of like intrinsic or ego resilience that exists as sort of a trait, like trait level resilience, that is something that you're born with, and that's just the way that you respond to it, which is something that absolutely exists. The flavor of resilience that I'm more interested in is more of a dynamic form of that you can use resources to build up a reserve of resilience effectively. So, and there are definitely intrapersonal factors that influence resilience as well. Resilience is such a complicated, as these several days have elucidated. It's a very complex construct that exists in many different flavors. So absolutely interpersonal factors influence resilience, the way that the coping mechanisms that you have, and that whether they be social, whether they be sort of intrinsic to yourself, these all influence your resilience. So you're trying to find some signal in a lot of noise, in looking at resilience, particularly in longitudinal studies. But you just hope that you have the numbers to be able to reveal some of that signal.
Hi, Theodore. Elina Birmingham from UBC. Thanks so much for the talk. And thank you for bringing up your definition to begin with of resilience, because it gives me a chance to open up the discussion. I'd love to hear your thoughts about the whole concept of resilience and what's a good way to approach it. And I'll be honest with you, my first response to the definition you presented was that I felt like, oh, that doesn't capture everything that I feel resilience should capture. And so I was really glad to hear you, just the last response to the last question, that you were thinking about more complex ways to understand resilience. So I wanted to throw something out there and get your thoughts on that, especially in the case of the result that you described and that approach of, so you define resilience as a more positive response to adversity than expected. And so I imagine expected is the average response. So if you take 100 people and you put them through trauma, and 20 of them develop trauma and 80 go away with just stress with no trauma, would we call that 80 more resilient than the 20, right? So that would be according to that definition. But what I want to bring up is the possibility that there might be a longer scale type of resilience that actually looks in the shorter scale like non-resilience. So a person gets traumatized by something, but in that process, then they're able to learn from their trauma and from their negative response in ways that then make them better able in the future to handle adversity, while the other people who the same experience didn't collapse, they didn't traumatize, and they looked more resilient in that moment, actually didn't change much about the way their minds configured, the way their brains configured. So in the future, they might not be that growth going on in the future. So what do you think about this longer scale resilience where the effect involves a shorter scale collapse effectively, but that then people have the resilience to learn from that collapse and weather through that very negative and sometimes long time, and then change their life in ways that the people who looked resilience and their friends, and they talked about it and everything was fine, they didn't think much about it, they couldn't do that. So in essence, I'm proposing this idea of openness to adversity, openness to the experience of adversity that may look some people look like, may make some people look less resilient, but actually in the long run might make them better able to adapt to changing circumstances and cope with future resilience. So adversity.
Yeah, so I think what you're describing is sort of people, if I understand it correctly, is that people experience an adverse event and then they deal with it in some capacity, and they sort of build up the capacity to deal with greater adversity as they get older. So Michael Rutter is a British psychologist or psychiatrist. He coined this term called stealing, like S-T-E-L-I-N-G, not S-T-A-L-I-N-G, where you like steel yourself against adversity. And this is taken from a lot of the resilience work, as has been discussed previously. It comes from child psychology and looking at children that have come from adverse backgrounds but have positive outcomes. And this whole stealing concept really revolves on the fact that children that are exposed to increasing levels of adversity, but they are able to build up the coping mechanisms or the skill sets or whatever it might be to deal with those adversities, they actually end up being able to handle greater adversity in as they get older. So they're basically building up these sort of resilience resources to be able to steel themselves against adversities that they might experience in later life. And the opposite end of the spectrum is where the children who didn't experience any adversity at all, so they were really sort of protected and from any type of adversity when they were children. They didn't have to deal with that, so they didn't have any negative outcomes from it when they were children. But then when they became older and they actually experienced real adversity as an adult, they hadn't built up the same types of coping mechanisms or resources that they could access that the children who had experienced adversity had. So Michael Rudder and stealing is, I think, is something that you're describing, and that it is a very individual process. And on the one important thing to note is that there's definitely like toxic adversity where you can't inoculate somebody with a ton of adversity and just expect them to take it. Some people have lower thresholds for the capacity to deal with adversity and don't develop resilience or don't steel themselves. They just they sort of succumb to that adversity. So that was my very long-winded answer to say that resilience is experienced and developed and changes throughout the life course. You're born with some of it, with a form of resilience, and that there's also ways that you can develop it over your life course by facing adversity and building it up by being resilient. You can foster greater resilience and vice versa. So I hope that answers your question. Sorry.
I believe this is another question on Zoom from Andrea. How can we know whether it is the individuals with better mental health who are more socially engaged over their lifetime?
Sorry, can you say that one more time, or who had is if it's in the chat, was that?
It's in the chat from a few questions ago from Andrea.
Oh, okay. Yeah, so this is again, this is an excellent question, and it really speaks to the noise that you get in trying to capture resilience. I think that there's absolutely going to be people that you get these things where people that have better mental health, maybe more socially engaged, and you get that sort of reverse causality challenge where are people depressed because they're not socially engaged, or are the people that are they're not socially engaged because they're depressed, that type of thing. So I think that from a researcher perspective, we can do our best to adjust models to try and look at adjusting our models for capturing mental health across the life course and looking at trying to isolate variables as best we can, but that in the complexity of the aging process is virtually impossible, because we're never going to be able to adjust for everything, and we're never going to be able to isolate our exposure and our outcome. What we can do is try and triangulate studies. So looking at a number of different studies from using different methods and different sources, different places, and if they're all pointing in the same direction and providing evidence for a specific relationship, that really strengthens that evidence base. But that, again, that's a long-winded answer. Is the short answer is that it's really difficult to know, and I would think that people that have better mental health are more socially engaged. But I think there's a component in that there where social engagement also fosters better mental health, and so yeah, we try and do our best. But this is again, epidemiology does a great job at pointing the relationship between X and Y, but we really don't know specifically what is the causal mechanism that underpins that relationship.
Okay, thanks. We have an audience question. You have the mic.
Hi, Cindy. This is Emma from SFU. I was wondering what your thoughts were about the how resilience, and you mentioned resilience reserve, how that fits into the context of cognitive reserve. And the second question is, it similarly to what happens with cognitive reserve, for those with higher reserves, once a functional threshold is met, the decline rate happens at a faster pace for those with higher cognitive reserve. If you think that would be similar for those with higher resilience reserves. Thank you.
Yeah, excellent question. Yeah, I think that cognitive reserve and like resilience resources are definitely related in that if you have sort of a bucket from which to draw resources, and you have more in that bucket, then you're better able to deal with that. And again, and to your point as well, I think that if with cognitive reserve, if you fall below a certain threshold in your capacity to deal with cognitive load or whatever that might be, then that's when you start presenting clinically. Similarly, I think that if you have a more resilience resources that you can draw on, you're better off. But if you have fewer, but eventually that sort of bucket is going to run dry, and then that's when you start facing sort of deficits, and that's when you sort of get clinical presentations or you get impacts on your mental health. This is a sort of a common theme in a lot of these reserve hypotheses across the aging literature, is that you can build up your capacity to deal with something, but once your resources have been depleted, that's when you start facing the negative impacts of that, and that's when things start to present clinically. Yeah, excellent analogy there for sure.
There's a question from Bryce Phillips in the chat. And do you think two-hit hypothesis could be applied to the follow-up research where individuals experience early life adversity and this predisposes them to more adversity later in life, and that leads to mental health issues?
Yes, I do. Yeah, I think that what we found in this study was that, yeah, people that experienced greater early life adversity had poorer mental health outcomes. And although we didn't have metrics, the same types of metrics for that were used to capture early life adversity in later life, these are something that I would anticipate there being greater adversity. If you look at sort of models of social determinants of health, that type of thing would definitely apply here as well. You know, people that come from lower socioeconomic positions, they're born into lower socioeconomic positions, they're more likely to experience those for the rest of their lives. So I think that would tie in with that. If you look at social determinants of health as a model for that, early life people that are part of the components of early life adversity were highly associated with low socioeconomic position, and we expected that to carry through. There's not a lot of, particularly in the post-war Britain, there was not a lot of social mobility. And so people that were born into these sort of lower socioeconomic positions stayed in them throughout their lives, and they did experience greater adversity, depending on your definition of adversity. But and that it saw that there were, in this particular study, that there were poor mental health outcomes for these individuals. So yeah, well spotted.
Any other questions from the audience? Not seeing anything. Is there anything from Zoom? Okay, well, it is 10:43. We are on time. I want to thank you so much again for your presentation. That was really fascinating, and appreciate the discussion. And hopefully we'll see you again soon. Are you going back to SFU at some point?
Yeah, I'll be back at some point, not for a little while, but before we go, shameless plug, go follow our Instagram account at Precision Mental Health and check out the website at precisionmentalhealth.ca, and there's a lot more information about some of the work that we do at the lab.
Yeah, I was actually wondering if there's anything going on like this, the similar kind of longitudinal study in North America, or is this data initiative, it's all in the UK?
There are absolutely North American studies, one of which that I'm involved in is the Canadian Longitudinal Study on Aging. But the British model of recruiting babies is incredibly effective. The retention rates on the 1946 birth cohort study are close to 60 or 70%. There's some of the, if you do deep dive in it, there's some ethical challenges that would have been faced if you used that model today, because they were basically just forced to do it when they were kids. But they've tried to do it, but the retention rates are very poor. They tried to do the Millennium study in the UK. They tried to do a birth cohort in 2000, and it failed. It just couldn't recruit people, couldn't keep people in the study. So the British model is interesting, and definitely a lot of just being forced to do it. Like chatting with some of the participants at the birthday party, they said, yeah, we got pulled out of class when we were in grade school, and they just made us do the tests. So probably wouldn't fly in today's research.
Yeah.
Things have changed a bit. Okay, that's wonderful. Thank you so much again. Appreciate it. All right. Well,
Sure.